Hi Saili, are you unable to hear me? Okay, so yeah, a very good evening, and yeah, it's a little unprepared entry from my side. So give me 2 minutes till I just put on my headphones and other things, right? I'll just take a minute more. So today we are talking about extraoral radiography. To start with, we'll be talking about the panoramic radiography. Right. Now, panoramic radiography, also called as pantomography. Now, here what we are exactly doing is, we have the structures and we want all the structures to be seen in one big radiograph. So what, if we want our whole jaw to be recorded in one radiograph, when we record from this side, the other side picture, it appears on the back side of this image. When we record from this side, the right side picture appears on the back side. And ultimately we are not able to get an open kind of an image if we just take a simple radiography. But in pantomography, what we do is, we just use the focusing principle, and herein we make the surrounding object blurred. So basically what we are doing here is, we are making the object which are not of interest blurred, right? So here today we will see how we do that. So what we are trying to do is, whatever we want to record, we'll try to refine or make those things sharp, and whatever we don't want, we'll make those structures so much blurred that they will not interfere with our observing of the structures which we are interested in, right? So so this, when we talk about okay, bear with me today. This class has been taken by me in last year, and so today it's like I'm just repeating Dr. Daisy, so I'm not aware of the sequence of the slides. So just bear with me. I may be a little slow. If all doesn't go on well, we'll just wait for the things to get better at Dr. Daisy's end. Okay. Other than OPG, we use the same approach that we'll be seeing in the future slides for curvilinear variant of conventional tomography. So when we actually see the concept of OPG, we'll be able to understand the concept of tomography as well. And the concept says, its principle is the reciprocal movement of the X-ray source and the image receptor around a central point or a plane, which is called the image layer. So what exactly we have here is, we have an image layer in between. Okay, this is our central area which we are trying to record. Okay, on one side we have the image receptor or our X-ray film. Okay, on this side we have our source of X-ray. So what is exactly happening is, we are moving this around the image that we want to record, and because of this movement we create an image of the object of the interest. So our object of interest are lying inside a plane which is called as the image layer. Yes, it's a reciprocal movement of the film and the tube around the object. Now how does that work? Right? Now initially when the principle of panoramic radiography was given, it was, let me just jump to this. It was something this way. Let's see how it goes. Here you have a disc 1. You notice here, this is our disc 1. Okay, this is our X-ray source. Right? And this side we have a film. Now if we rotate the film in this direction and rotate the disc wherein we have these radio opaque objects A, B, C, D, these are the radio opaque objects supposedly, right? We are rotating this in this direction. So what will happen is, this particular disc is going here, right? Further disc is going here. They are going at the same speed. Okay. So when A comes across this slit, film will come here and the image of this A will be formed on this film over here. Now our disc rotates even more, and next the B will come in the slit. Okay. Now the image that we have already created of the A will now move somewhere here. So will our A, this A will also come here. Now the B key image will form in this particular area. Getting the point? So basically what is happening is, the object is also rotating, the image is also rotating, and they are passing through the X-ray beam, and they are synchronizing. So every time an object displays an image, now the film moves and then the next object displays its image. So it's like a moving film and a moving object. So this is a basic concept of OPG. But now imagine a patient over here. Okay, we want to record this particular tooth to this particular tooth, right? Fine, we do this, but what will happen? A patient will keep on rotating, and ultimately he will start feeling dizzy. So that's not kind of possible, isn't it? So what we do here is, now we achieve the similar scenario by moving the X-ray tube and the film. Herein, we want the same results, what we are getting with this particular experiment. But we want the same results without moving our patient, right? So what we exactly do is, let me just skip through this. See, now in this particular diagram, what we are doing here is, we are keeping the object or our patient stationary. We are moving the X-ray source. Okay. Now look at the point of movement. We are actually revolving the X-ray source and the film, right, around the point, around the object. So X-ray and the film are going this way. Not only that, our film is also rotating so that every time a new point comes in between. Getting the point? Hopefully you know the rotation and revolution ka difference when we talk about it. Something like sun and the moon. I mean, isn't it? It's the same concept over here. Now look at this. Imagine this particular disc now goes in here. Okay. Our object is stationary, our slit goes here along with this. Okay. And our X-ray tube now comes here. Okay, it will here, and our disc will come here. But not only that, disc will rotate here so that A moves here and B comes in front. I mean, B key position comes in front. Getting the point? So ultimately we are getting the same effect without moving the patient. That is the basic concept of panoramic radiography. Right? Now let's go back to our slides and see what we have in there. Okay. The first one to describe the principles of panoramic radiography was Patero. And working independently we had Numata. So these are the names for you to remember. Okay, let me write it here. As usual, as I say, have your scribble notes ready, have your stickies ready. Let these names go in your stickies and to your walls ultimately. Patero and Numata. Okay. What principles, what advantage we get with the panoramic images? We have a broad coverage of the facial bones and the teeth. You all very well know how OPG looks. And since we get everything in a one particular radiograph, there is a low patient radiation dose. Now imagine if we have to take every tooth, in IOPA you all know, full mouth IOPA, it requires so many films and so many times the patient gets exposed. So obviously patient exposure is less with OPG. There is convenience of examination for the patient. Of course, he has to sit and, only for the one time, until we rotate him, of course. If you're not rotating the patient, he'll be quite convenient with OPG rather than with IOPs or, multiple radiographs. Ability to use in patients who are unable to open their mouth, as in positioning IOP, especially with the patient with gag reflex and small opening of the mouth is such a pain. So for such patients, this is very good. Yes, in the cases of trismus wherein they are not able to open their mouth, and all those cases, fractures, many cases. There is short time required to make panoramic radiograph, usually in the range of 3 to 4 minutes. Right? Including the positioning of patient and cycle, everything, it just takes 3 to 4 minutes. Rather, when we talk about the IOP, multiple IOPs to cover the whole mouth, it will take so much of time. Further, it's a very nice visual aid in patient's education and in case presentation. As compared to IOP, which is difficult for us to explain to the patient, OPG will be rather more convenient and easy because you can actually show him the whole picture of the mouth. So these are some advantages which are very obvious. So I don't think so there need to be much of putting in of head in these points. But the main disadvantage are we do not get fine anatomic details. Now, if we are supposed to locate a proximal caries, if we are supposed to, find out the actual amount of bone loss, or if we are looking forward for a percussion involvement, and all these kinds of smaller details, we do need IOPs. We cannot rely on OPG in such cases, right? So that's a very direct, well-known disadvantage of panoramic radiography. So we've gone through the principle, right? Okay, I'll just not go through these details. It's given in your keynotes, and it's the same as what we saw. So if you just land up forgetting the principle, read the chart, it should help you in understanding the same thing, right? Okay, now when we already saw the principle, that was we had the disc in the center. Now replacing that particular disc with the mandible so that we can actually get an OPG. Look at the thing. Now remember our disc, what we saw in the experiment was a round disc. When we talk about the round disc, it has one center of rotation. So the case becomes simple, right? Your X-ray tube and your image receptors moves across one center of rotation. Okay? But mandible is not a circle. So the problem now here comes with the center of rotation, right? Now here what happens is, normally in OPG there is shift in the center of rotation done so that we create the proper images. We'll be talking about these, how many center of rotation and what effect they cause and all those things in probably the future slides. Now look at this point. Here we have, in this particular diagram, we have two center of rotation. In the first half, when we are imaging this side of the mandible, our X-ray tube and the film are rotating across this particular center of rotation. As soon as we reach the midline, there is a sudden shift of the center of rotation to this particular point, and then the tube and the film revolves across the second center of rotation. Okay, why we are doing this is, we are trying to have this particular curve of one half of the mandible as one arc, and we are using a center of rotation that best suits this particular side of the mandible as one arc, isn't it? So that it becomes a kind of smooth movement, at least recording one half of the mandible. And again, in the second time, we are taking this particular half as a reference, and we are selecting the center of rotation depending on this particular half. But in whole scenario, something goes wrong. What goes wrong in here? There is some part of the mandible that gets neglected and which doesn't actually get a good center of rotation, and there the image is blurred. So can you just guess which part is that in this particular diagram? If we have just two center of rotation, which part would probably be the most blurred part in our this thing? What do you say? Others? Saina? Sushma? Rashmi? Saini? All agree with Uday? Yeah, so basically what is exactly happening is when we are reaching here, then there is a shift in the center of rotation, and we actually targeted this particular portion, but this particular portion was not taken care of because the center of rotation was not related to that particular thing. Now imagine a scenario if I put 3 center of rotation. Okay, I mean when the X-ray is sweeping, okay, let me just clear the mess. I usually mess up my whiteboard. Okay. Now in the second scenario, we are creating 3 center of rotation. Okay, first center of rotation will record the mandible from here to here, you can say, and then there would be a shift that records the mandible from here to here. Then there is a shift that records the mandible from here to here. Okay, now probably we have focused anteriors with this particular center of rotation, isn't it? Now again, do we get any blurred images? Do we still get the blurred images in any particular zone? What do you say? Feel free to answer, guys. It's okay to be wrong. Why lingual? I mean, I may probably fix the center of rotation based on its lingual arc too, if I have to define. Or usually it's at the center of the crest, Basically, a center of rotation is trying to keep the object which we want to record in focus. So, I mean, why particularly lingual say? Okay. You know what? The question is, now, initially we had 2 center of rotation. One center of rotation was depending on the curve of the left side of the mandible, so that we get a good image of the left side of the mandible. As soon as we move on to the right side, we shifted our center of rotation to the other center so that we get a good image of the right side. Therein we had a problem that our anteriors were blurred because our center of rotation was based on the side of the mandible, and the curvature of the anterior was quite different, and we did not focus that particular thing in our previous 2 center scenario. But in this scenario, we have 3 centers of rotation. In first one center of rotation, we targeted this particular portion of the mandible. We recorded this particular portion of the mandible. Then we shifted the center of rotation such that it suits this particular portion of the mandible. And thirdly, we shifted the center so that it suits this particular portion of the mandible. Now my question is, do we still get any zone wherein we have blurred images? Remember, in the first scenario, we got the blurred image in the center. That was a zone when our OPG machine was shifting the centers. In this particular time, we are shifting the centers in these particular zones. Have you ever seen an OPG image wherein you see very good incisors, very good molars, but you see a haziness in premolar zone? Have you seen such an OPG? I know you people are of new generation and you see very good OPG images actually, so that is the reason maybe. Remember that this particular zone you would have seen, there are 2-3 items. If you actually notice seeing the OPG images, you would see some kind of films wherein you see haziness totally in the center. There is some kind of film wherein there is haziness in the premolar zone. Isn't it? When we have that know what exactly has happened. Yes, I know we'll talk about why the structures are not overlapping. I know, you know, why you feel that this particular thing and this particular thing is not overlapping when our image is going through this, isn't it? That's what is the concern, isn't it? Isn't it, Saina? Okay, let me clarify that part before then we discuss about the blurring of images. Yeah. See what exactly happens when we want to record this particular image in here. Okay, this particular, what we want to record is we want to record the mandible. So we want to record this particular thing. We don't want to record the structures outside it. Okay, now listen to me, okay, focus on what I say first. Okay, then we'll discuss about what happens. Okay, so normally when we take a radiograph, how it happens is the radiograph passes through the object and it puts an image on the thing. Here what happens, our film is also stationary, our X-ray source is also stationary, right? But herein our X-ray source and film are moving. But when we say moving, okay, now let me go to the principle of this thing first. Okay, when we say moving, okay, see this scenario, when the A comes here in the slit, okay, and B comes here. Okay, when this comes like that, at that particular time, this, sorry, A comes here. This A is relatively stationary to this particular A. Are you getting the point? It's moving, but when the X-ray is passing through point A and you know the image is falling on this thing, it becomes relatively stationary. At that particular time, they are not moving. Okay. Now that why that happens? It's something like, you know, when two buses are moving in the same direction, okay, in the same speed, the people from one window can talk to the other window. It's a simple logic, right? Yes, they're moving at the same rate. So here the film is coming like this, and you know they are coming straight on to each other, and they become stationary and they face each other. They are stationary with related to each other. But imagine a scenario. If our disc was moving in this direction and X-ray was moving in another direction, I mean, imagine it if they rotate in opposite direction. What will happen? They will not be stationary. In that particular case, how will the image form if they are not stationary with relative to each other? The image will be distorted, isn't it? It will be so distorted that it will appear blurred. Right? Why that happens? Because yeah, now let's see, you know, in this particular scenario we are just passing it through one point. Here is what happens, let's see. Okay, now look at this particular point here. This particular point is getting recorded. You know, the film comes here, right? And our center of rotation makes this particular thing which is close to the image gets recorded here. But what is happening to this particular portion through which also the X-ray is passing? See, we are not concerned about this portion. Are you understanding this particular point? We are not concerned about this portion because our collimator is making sure that our X-ray is not, you know, whatever X-ray is falling here is not going to the image receptor. Only the X-ray which is passing through this slit is going to the image receptor. That our collimator is making sure. But the problem is, this and this point both are, passed by the X-ray. So we expect that maybe this also gets recorded and this also gets recorded, isn't it? But because of the center of rotation, what happens is this X-ray beam, sweeps through this part so fast, it's moving through here so fast relative to how it is moving on the film, that image of this particular zone through which the X-ray is passing gets blurred. And this particular zone where the X-ray is passing with same speed as the image receptor gets sharp. So actually we record both this point and this point. This point and this point, but this particular zone is so blurred that it does not interfere with the visualization of this particular zone. Getting the point? It's not that we are only recording the object of interest. We are recording the object of interest plus the object not of interest, but the object which is not of interest, we are blurring it off because of the fast movement of the X-ray. Unsynchronized movement of the X-ray through that as compared to the film. Basic relation is between the speed of, on the film and on the object. Right? Hopefully that makes it clear when we come, when we have the X-ray over here. Okay? Or anywhere, we are actually passing the X-ray through two layers, but we are only recording one layer because the other layer gets blurred and it does not interfere with the thing. Right? Now, that is why we need our rotation to be such that our speed, object of interest, speed of X-ray through object of interest and on the image receptor is same. That is the basic reason why we actually shift the center of rotation. So when we are keeping our center of rotation here, what we are trying to do is, we are trying the scenario such that our X-ray sweeps fast on this particular area and it sweeps synchronously on this particular area, so this is recorded. Getting the point? When we shift it over here, the opposite happens. Confused or clear? I know it's a little confusing as far as OPG's imagination thing is concerned. Okay? Okay, Rashmi, okay, fine. Now look at this particular point. Now here the problem was when we were doing this, we actually focused our center of rotation with respect to this particular arc. Since our mandible is not a round thing, what happens was, if it was a round thing with one center of rotation, when it was a round thing, how we arranged the movement of the X-ray was that this particular object was always in focus and this particular object would pass in speed. Isn't it? That was so simple because the object was round. But here the object is not round. Since the object is not round, to achieve this particular scenario, so that this particular object is part is focused, this particular part is focused, what we have to do is, every time we need to select a center of rotation that is favorable so that recording of this part happens. Isn't it? Now, initially they used to use two-center rotation, wherein they selected a center of rotation which was very favorable to this part. Okay, when we selected two center of rotation, we selected for this part, but this particular part we did not get a very good center of rotation that relatively kept X-ray and image receptor well synchronized. That is why we got the image of this zone blurred. Yes, that is double center of rotation. Then Rashmi, what they did was, because of this problem, they included one more center of rotation. Okay, when they included one more center of rotation, that was with respect to this particular zone, we got this particular zone clear, this particular zone clear. But again, if you see, the center of rotation was not very favorable for the premolar zone as of now. So relatively, I say relatively, premolar was still blurred, although not as blurred as the incisors were before, but still it was relatively blurred. Actually, what we desire is, we want center of rotation for every point in the mandible. We want a kind of center of rotation that would actually suit every point in the mandible. So now what we have is, a new concept is, there is a dynamically changing center of rotation. So as the X-ray sweeps, the center of rotation keeps on changing. Getting the point? It's something like a camera लेके ऐसे से move करने वाली बात है. Continuous movement of the cameraman is happening. Isn't it? If you imagine the scene. Okay? Yeah. If there is a continuous changing per particular point, even if there is a little bit, blurring, since the blurring will be so uniform, yes, 3 center of rotation principle, and then the dynamically changing center of rotation. Okay, understanding the thing, you can have, more the center of rotation, more, proper orientation for every point you will get. Now, why we were seeing those blurring, it was relative, because as soon as we change the center of rotation, this particular zone was nicely focused. Now, if you have continuous change of the center of rotation, although there may be slight blurring of the structure, the adjacent structure, but since, it will be so uniformly done that your eyes will not notice that blurring. Getting the point? If suddenly center of rotation was changing, that particular time you were noticing that particular blurring in that zone. Isn't it? Yeah, now when it is dynamically changing, every adjacent point is getting focused every time the recording is happening. Yeah, moving rotation center, right? So hopefully that makes the things clear about the center of rotation. Right? Now, whenever we have a center of rotation, this center of rotation, the aim of it is to keep this particular object in a particular zone wherein, the image, that particular zone comes totally stationary with respect to the image receptors. That was our main purpose of having the center of rotation. We wanted our object to be stationary in relation to image receptor. If our object moves, so we want our object to move at the same speed as the film, so that it is relatively stationary. If the speed changes, if the image is moving slow or if the object is moving, slow, in either cases there will be distortion of the image. How the distortion will happen, we'll talk about in a while. Let's just go back and look at where we are. Okay, hopefully till this particular point everything is clear. Great. Okay. Okay, now the same things what we discussed over here are in the slide. The rate of the movement of the receptor, that is that film behind the slit, is regulated to be same as that of the central ray sweeping through the dental structures. Right? So our central ray is sweeping with the same speed as the image receptor or the film is moving, so that we get a stable image. But the structures on the opposite side, That is, we are talking about these structures. Okay, but the structures on the opposite side of the patient are distorted and appear out of focus because X-ray beam sweeps through them in the direction opposite to that in which the image receptor is moving. So you can imagine it's just the opposite movement. So the motion is so high that there is so much of blurring. Okay, that is the train moving in opposite direction. Now structure near the X-ray source, okay, are so magnified that they are seen as discrete image on the resultant radiograph. Clear on these points? Stop me if anywhere you lose the focus, because once we move on, it becomes really difficult to think back again, you know, what's wrong. So just keep evaluating yourself whether you still have a doubt or are the things clear. Okay, so do not hesitate if you still feel no, it's not the way it should be. Okay, this is the time we can have our concepts really clear, because as we move closer to the exam, every time we try to understand and spend time on understanding concepts, we feel scared कि अरे कितना time लग रहा है. Okay, so that makes the things very difficult when we go near the exam. It makes the things very difficult for us to understand. So your main focus in your preparation of the early days should be to have your concepts so clear that when you move towards the closer to the exam, there are some things which you will never forget. Okay, so please do not hesitate if you have the if you feel I'm not very clear on a particular point, we will try to work it out. Okay. Okay. Now, when we were talking about an mandible and our image receptor over here, okay, and we were changing the rotation point for our X-ray. Okay, what we were trying to record is, we were trying to record every time this particular structures which were closer to the image receptor or the film. Okay, ultimately if we see, we will be able to record the structures which are in a particular zone. You know, probably this particular zone, which was very favorably recorded on the image receptor because our movement were in sync with the image receptor. So if our structure lies within this particular trough, okay, this is called as focal trough or the image layer. If a structure lies within this, it will be clear and recorded on the image receptor. If it lies outside, whether here or whether here, what will happen is the structure will be distorted. Now, when we are actually analyzing this particular diagram, you know, if you see, in a particular this scenario, what do you say? Clinical scenario. In diagram, how you see is your mandible is totally snugly moving with the image receptor in this particular representative diagram. But imagine the scenario in the clinical case. Patient को चिपका के नहीं move करता है image receptor. Image receptor has a little bit distance from the patient when it is moving around the patient. Isn't it? We cannot have the patient's cheek or mandible fixed to the image receptor, the way we are talking about in here in our diagrams to understand it. Right? Have this particular point clear. But when we actually are moving, when we are actually moving the film and the X-ray tube, we are trying so that the speed of the film and this particular zone, speed of this particular zone is same. Okay? There are still structures which are closer to the film over here. Isn't it? These structures which are closer to the film, although we don't have it much of the air, but if there is a structure which is closer to the film, Okay, that structure will not be exactly lying within the focal trough, and that structure will be distorted. Same will happen to the structure which are outside or away from the film. Okay, what kind of distortion will be taking place in these structures which are closer to the film or which are away from the film need an understanding of how the X-ray sweeps through these structures. Okay, so if you have that particular diagram thoroughly clear now, we'll move on to see the effect of the moving of the, or keeping the object closer or away from the image receptor. Fine, all clear till now, the scenario all clear till now, so I'll move on with the next point. Okay, now let me have that other picture also handy. It was in slide number 11, okay. Okay, now what happens to the structure? Now we all know the concept of the focal trough. It is that particular area wherein the X-ray is passing at a proper speed with respect to the movement of the image receptor. Now this side is our X-ray tube and this side we have our image receptor. Let me draw it a little bit far actually as the scenario is. And this is the focal trough wherein this is the focal trough wherein you will get the sharp images. Okay, I mean when depending on the center of rotation, the X-ray will sweep in this area very precisely so that it is the same speed of movement of the image receptor. Now if our object, what will be the object? Object will be either mandible or mandible teeth. If that object moves here, let's first go to the lingual side. Okay, if our object moves towards the lingual side, that is towards the X-ray source, what will happen is, the movement of the arc, right? Since if we go closer to the X-ray source, what will happen is, since it will come closer to the arc, the X-ray will sweep through it slowly. If something comes closer, what will happen is X-ray will sweep through it slowly. It's simple arc rule. Let me just have it. This is one particular line. एक stone बांधा है तुमने, and you're just moving it in a circle. Okay. Okay, the point which is closer to the arc of rotation will move slowly. This concept, hopefully this is a simple physics concept and you understand this point. Whatever will be the closer to the arc of rotation will move slowly. Okay, fan maybe you see the center part, you don't see the bahar ke things because it's moving fast. The center part is visible because it's moving comparatively slow. Basically speed of the rotation is same, but the point, the distance covered is different, right? The same thing happens. If you are just moving the object closer to the X-ray tube, it's coming closer to the arc of rotation, so X-ray will pass through that particular object slowly. Okay, now this is our object. Okay. Now X-ray, if it passes with the same speed as that of the image receptor, we get a nice image, correct size image. But now imagine the X-ray is going slowly through it. Okay, and पीछे के side में your image receptor has moved fast. Okay, now when the image is forming, image receptor इतना move कर गया है कि you get a horizontally elongated image. Getting the point? Horizontally elongated image. So it's just not the term elongated, it's horizontally elongated because how we are going is इसमें भी इतना धीरे धीरे इमेज एक्सरे जा रही है कि वाइड, यस साइन है, इट्स वाइड. हॉरिजॉन्टली इलॉन्गेटेड इज नथिंग बट वाइड. Imagine that your object has moved outside here. This was the optimum zone. This was the trough. Okay, now it has moved outside the trough towards the side of image receptor. Abhi arc of rotation mein it's moved outwards. It's moved outwards, right? So now what will happen is, now the X-ray will sweep through it fast. Jaldi se chali jayegi usme se, isn't it? When it goes through it fast, image receptor is still moving at the same speed, right? It's not moving in sync with this particular position right now. It's moving in sync with this position. Getting the point? So X-ray will sweep through it so fast that whatever image will be formed will be a narrow one. Clear? This is a very important question in your MCQs. Okay, now what happens is, you may try to remember, it sounds very simple that objects which are closer to, which are inside, closer to the X-ray tube or inside the focal trough towards the lingual side are, wider horizontally, and which are closer to the image receptor or away from the X-ray tube are narrower horizontally. ऐसे लगता है दो ही तो sentence है, right? You will see there are only two sentences. I can remember it. Don't do that. At least remember the Pan principle. And if something sweeps through slowly, it will create a wide image. And if something sweeps through fast, it will create a narrow image because जल्दी से X-ray उसमें से चली जाएगी और पतली सी image बन पाएगी. Okay, so at least remember that arc zone. That will help you remember the concept. Okay, try to solve the questions today on this. अभी इसको पढ़ लेते हैं. When the mandible is displaced towards the buccal aspect of the image layer, the beam passes at rate faster than normal. What was the normal? Normal is matching the image receptor speed, right? When it goes faster than normal, the image becomes thinner. That's it. Okay? Now there are other things also. These are simple, right? Chin position. It's simple. If the chin position is downward, right, you get a smiling face. If the chin position is upward, you get a frowning face, right? ये तो simple imagination है. If you people actually do the drawing and all that, it will happen in a simple drawing. Any face, if you tilt it upward, you will notice that my face ka arc has turned ulta, isn't it? So it's simple and straightforward. I'll move on with this one. Okay. So all clear with that? All clear with the panoramic radiographic concept? There may be few other things which we will be coming across, like which particular structures are seen in which particular radiographs and all those things. Most of those things will be focusing with MCQs and with oral surgery, the fracture classes and all those things. Right? With this we move on to the extraoral radiographic technique. How receptive are you guys? Shall we move on? You need a break. Yes means a break. Okay, right? Okay, chalo, so I'll move on for a little more time, and if you feel a little saturated that particular time, we'll take a break. Okay, so we are talking about the extraoral radiographic techniques. Now first we'll talk about the lateral cephalogram. Now all the extraoral radiographic technique other than the, the panoramic radiographs and those particular things, most of the other radiographic technique, what we have to remember is how you have to keep the image where the beam goes from, and it's quite a bit of memory based, and the best thing would be to see the diagram along with it. You have the diagrams in your keynotes as well as far as I know, these kinds of, isn't it? So you can just have a look at them when you're reading it. Okay, so when you talk about the lateral cephalogram, here the image is positioned parallel to the patient's mid-sagittal plane. So this is, are you able to see the image? Okay, so this is the mid-sagittal plane. Our image is parallel to the mid-sagittal plane, and the site of interest is placed toward the image receptor. So our site of interest is towards the image receptor to minimize the distortion. In cephalometric radiography, the patient is placed with the left side towards the image receptor. Now, whenever we are taking a cephalogram to look into a particular pathology, the pathology will know the contour side mein. But if we are taking, if we are taking it for cephalometric analysis, then it's the standard side we keep towards the image receptor, and we keep the left side towards the image receptor. If you know the name, do you remember the name of the person who gave the panoramic radiography? Ferrero, kya tha? I forgot. Patero and Numata. Numata is fine. Okay. Well, close enough. Quite low. We can select from the options anyways with this one. Okay, so here in one more point to remember, in cephalometric radiography, the patient is placed with the left side towards the image receptor. The film is positioned parallel to the mid-sagittal plane, and the central beam is targeted perpendicular to the film. A very direct one, simple one. I'll move on with this. Remember the picture, remember the point. Okay? Next is submental vertex or the base projection. Yeah. Look at the diagram here. Okay, if you just see the name, it's submental vertex. We are going from the submental region to the vertex. Okay, most of the times the name will give you the total hint. Now, head position is patient's neck is totally extended backwards, and film is positioned, perpendicular to the central beam. Wait a second. Okay, we are missing a reference line. Give me a second, I'll just get back to you on this. What is the name of that particular, this is submental vertex we are talking about, but when we actually take an underexposed view to expose the zygomatic arches, that view has, yes, it's called a jug handle view. You can imagine, it's a nice space that looks like the body of the jug, and zygomatic arches look like the handles of the jug. That is why it is called as jug handles view. So jug handles view is nothing but another name of submental vertex. And in submental vortex view, as we already saw, our patient's head is positioned such that camphor-meatal line forms a 10-degree angle with the image receptor over here. X-ray is passing through 2 centimeters in front of the line joining the two condylar head. Okay, with this we move on to the Waters view. What are the 2 views we have completed? Submental vortex and lateral. Which side of the face is kept on towards the image receptor if we have to take a cephalometric? Okay, too easy. Okay, when we talk about the Waters view, the head is positioned. You know, herein the head is tilted upwards. Note this. Okay, head is tilted upwards, and camphor-meatal line is forming 37 degrees with the film. 37 degrees. Okay, so it's forming a 37 degrees with the film, and the central beam is perpendicular to the film, and we actually position of the central beam is at the level of the maxillary sinus. Now, whenever we are taking any extraoral radiography, there are 2-3 things. One is the position of the film. Second is the position of the facial structure. Mostly it's some reference plane in respect to the image receptor. The third thing would be the angle of the X-ray beam. Herein we already saw that angle is perpendicular to the film. And the fourth thing is the level or the area where we are actually focusing the central beam from. So herein it is at the level of maxillary sinus. Yes, it's 10 degrees for the submental vortex and 37 degrees for the Waters view. Okay, so in the Waters view we see a very good image of the sinuses. So it is a very good radiograph to evaluate the sinuses, air sinuses. And if you want to see the sphenoidal sinuses, they are very well seen if the patient opens the mouth while taking the radiograph. So if the question asks about the sphenoidal sinus, then you have to look for the choices that are asking about the Waters view with the open mouth. Okay? Clear with the points? Yeah, then we have the postero-anterior view. Now, postero-anterior is as obvious, it's postero and anterior as the name says. Film positioning, camphor-meatal line at 10 degrees with the film, and the Frankfurt's plane is perpendicular to the film. Okay, now the Frankfurt's horizontal plane, now let me see the diagram. Here we have, okay, a Frankfurt's plane is perpendicular and the camphor-meatal line is forming the 10-degree angle with the image receptor. A central beam will be perpendicular to the film. Okay, if I asked you what is the relation of the central beam with the Frankfurt's horizontal plane? Yeah, it's called as parallel. It's parallel to the Frankfurt's horizontal plane. Yes. Okay, this is about the cephalogram. But if you are taking a PA skull projection, if you want to actually focus onto the skull projection, therein instead of the Frankfurt's plane being perpendicular, we keep the camphor-meatal line perpendicular to the image receptor, getting the difference between PA cephalogram and PA skull. Okay. In PA cephalogram, we have the Frankfurt's plane perpendicular, camphor-meatal forming 10 degrees, but in PA skull, we have camphor-meatal line perpendicular to the image receptor. You see? Now, when we take a image, the image would be proper if the superior border of the petrous ridge lies in the lower third of the orbit. Okay, that's the criteria for PA view. The superior border of the petrous ridge, because we are imaging through the skull, right? It should project over the lower third of the orbit. Then we have the next projection, that is a reverse down projection. Okay, whatever radiographs which we saw before, can you tell me the projections wherein we tilted the patient's head upwards? Can you tell me the two projections wherein we tilted the patient's head upwards? Two projections. Yes, submental vortex and water's view. In submental vortex we tilted so much that the plane was 10 degrees to the centimeter line was 10 degrees to the image receptor, while in water it was 37 degrees. Okay, next we come to the reverse down projection. Here the patient's head is tilted downwards. Okay, centimeter line is minus 30 degrees with the film. Yes, Sushma, water and SMB. Minus 30 degrees with the film. The central beam is perpendicular to the film and the level of beam is at the condyles. Okay, at the level of the condyle. Do you at this point remember the level of beam in water's view? Yes, and what was the level of the X-ray beam in submental vortex? And here is the line joining the condyles. Perfect, Sushma. Perfect, Saina. Yes, alright. Okay, so all going good in here? Yeah. So here we are talking about the reverse down. Reverse down is opposite to the waters. If you see, here we are going 30 degrees downwards, and the central beam is perpendicular at the level of the condyle. Okay. To improve the visualization of condyle, the patient's mouth is open so that condyle head are located inferior to the articular eminence. This view is very good to view the condyles. Okay, reverse down projection. Then you have the lateral oblique body. Okay, when we talk about the lateral oblique, we have the different positions from wherein we can pass the X-ray beam. Depending on that, we have the types. So first one is body, wherein head is tilted towards the side to be imaged. So as the image पकड़ के उसके ऊपर. So the best way is you can keep your hand, and this is how you remember the lateral oblique. Okay. So film contact with the cheek at the molar area, and the lower border of the cassette is parallel to and at least 2 mm below the lower border of the 2 cm. It's not 2 mm. I think so. It's 2 cm. I'll have to confirm this. 2 mm is too less actually. It has to be 2 centimeters. So just keep this point. We'll just confirm this one. Okay. Okay, so I'll just come back to you on that. It will take a while till I find it. Okay, beam is aimed at molar premolar area. Again, the beam will be, for example, we go in here, we put the beam in molar premolar area and the beam is perpendicular to the film. Right? So that's our lateral oblique body and the beam is passing through the molar premolar area. Okay? Oh, it's here nicely given. Okay? It should be 2 centimeters, you know, you can't have 2 millimeters niche. Okay. Excessive head tilting may result in significant distortion. How much we were tilting it? We are just tilting it arbitrarily. Right? There is no angle given for that. But we are tilting it towards the side of the film. Insufficient tilting will result in. So basic purpose of tilting is we are trying to move this side's mandible away from the scene. So this mandible goes away and an X-ray beam are going through this particular the side of interest that is on the left side of the patient from there, and then we are getting the image on the receptor. So this is the lateral oblique body. Then we also have lateral oblique ramus. Again the same thing will be done, the tilting kind. The head is tilted towards the side being examined such that the condyle of the area of interest in the contralateral angle of the mandible forms a horizontal line. Let me just go with the diagram. Okay, so this side's condyle and this side's angle will form a horizontal line. We have to tilt so much. Okay, that this particular condyle and this particular angle will form a horizontal line. Okay, this is about the tilting for the lateral oblique ramus, and rest of the things remain the same. Only thing we have to do is cantilever line is 10 degrees with the film in this direction. Okay, hopefully you don't have that in your keynotes. It's just my slides messed up over here, right? Anyways, because I think in your keynotes you have it in the form of tables, right? Yeah. So it's a conversion error while table was converted back to Indian. Okay, so basically what we are doing is we are tilting the head towards the side being examined and such that the condyle and they come at a horizontal level and the center beam is perpendicular to the film centered over the bridge of the nose. So this is the bridge of the nose, you know. So our beam will come like this. Clear? Okay. 30 degrees. Where did we have minus 30 degrees angulation of canthometer line? Yes. And where did we open the jaws, open the mouth? There were two radiographs wherein we were opening the mouth with two different purposes. What is we opened it for? Which particular thing? For sphenoidal sinus, yes, Sushma. And reverse sound we opened it. Why did we open and reverse sound? Okay, so that it goes below the, to locate the condylar head below the articular eminence. Like it was coming behind, oh no, why? Simon? Simon, you will refresh maybe? Okay, this was about the lateral oblique ramus. Okay, then we'll be talking about the TMJ, diagnostic images. How good are you guys to go ahead? Do you need a break? We have just 2 slides for the TMJ imaging. It's your charts. So we're talking about them. Okay, so you'll better wind it up. Yeah. Okay. So first is the screening radiograph, panoramic. We all very well know that panoramic gives the images of the condyle. It gives a gross image. You know, it's a screening projection used for the condylar disturbances. Okay. Then we have transcranial projection. Transcranial projection basically helps in identifying the osseous changes in lateral aspect of the joint. Okay. Let me first go through the projection. Then we'll come back to its uses. Okay, so how do we project it? Film cassette is placed on the side to be imaged. So look at the film over here. Okay, look at its relation in this direction. Patient is positioned in a cephalostat. So patient is totally straight and so is the film cassette. The X-ray beam is directed downwards from the opposite side through the cranium and above the petrous ridge of the temporal bone at 25 degrees positive angle centered through the joint. Okay, now look at it, where we are coming from. Okay, we have hopefully in your anatomy you remember your petrous ridge over there inside in your middle cranial fossa. Okay, so we keep it, you know, here, and our beam is directed downwards and forwards. See it here? It's forwards, it's forwards and downwards. Okay, so when we talk about the downward angle is always called the positive angle. It's 25 degrees downwards and it's 20 degrees forwards. Okay, now where exactly? Now when we talk about 20 degrees downwards and forwards, हम कहीं भी डाल सकते हैं, right? But where exactly we are putting it? We want the X-ray to go above the petrous ridge. Okay, and it should pass through the joint. This side joint is to be imaged, right? Yes, it's 25 degrees downward and 20 degrees forward above the petrous ridge through the condyle of the side we want to image. This is the whole sentence that will describe it. Isn't it 25 degrees downwards, 20 degrees forward above the petrous temporal ridge through the condyle of the interest? Clear? Yeah. Now, what it shows the lateral aspect of the joint. Further, it may help in showing the displaced condylar fracture, and also it shows the range of the motion. But the problem are the ipsilateral pectus ridge is often superimposed over the condylar neck, although we were trying to, you know, see, we are passing our image from above the petrous ridge of this side, but this side the petrous ridge will actually form an image over the condylar neck. Okay, so our transcranial projection neck is having the petrous temporal ridge की image. And which side petrous temporal ridge is this? The ipsilateral, the same side. Okay? So that is why we are not able to see the neck. Okay? Now then you have the transpharyngeal view. Okay, this transpharyngeal is also called as McQueen's view. Here what we do is, the film is placed on the side to be imaged. Now look at this film over here. Here we have the film, and this is how the film is. Patient opens the mouth maximally. This is the third time we are coming across any particular X-ray where patient is opening the mouth. Okay, why he is opening the mouth? Because we want to avoid the superimposition of condyle on the temporal component. When we talk about the temporal component, it's the upper part of the TMJ, the temporal part of the TMJ. We want that to be separated. Okay, now how the X-ray goes? X-ray is directed superiorly is -5 degrees, so it is 5 degrees upwards and 10 degrees backward, 7 to 8 degrees from the anterior. Okay, 10 degrees, so 7, 8 or 10. Here in the diagram it says 10, the text says 7 to 8, so it's somewhere in the range of 10 degrees backwards. So it is 5 degrees upwards and 10 degrees backwards, and where we are passing it through the sigmoid notch of the opposite side. So इस side में film है through the sigmoid notch. See, after opening the mouth you get the sigmoid notch palpable. Do you guys know what is sigmoid notch? This is sigmoid notch. Okay? Yeah. So that's what is our McQueen's projection or intracranial projection, or what was the other name? Transpharyngeal or Parma projection. Remember the names, okay? Transpharyngeal, Parma projection, McQueen's projection. Then you have the transorbital. Here what we do is, film cassette is placed behind the patient's head perpendicular to the X-ray beam. Okay, film is placed just behind, right? And how the X-ray, now the patient head is tilted downwards. Yeah, intracranial. Patient head is tilted downwards 10 degrees so that camptometal line is horizontal. Okay, now the camptometal line is horizontal because patient's head is tilted downwards. X-ray beam is directed from the front of the patient through the ipsilateral orbit and TMJ. Okay, look at this diagram. It gives a very nice imagination. Right? Okay, this is the cassette. Camptometal line ऐसे थोड़ा सा नीचे किया है. Open the mouth and through the orbit we are trying to pass through the side of the TMJ we want to examine. Okay? Look at the tilting, sideways tilting of 30 degrees of the head. Basically what we are trying to do is we are trying to make the condyle, the ramus, kind of perpendicular to the Obviously image, what we are trying to do is putting it from the front backwards. It's an anterior posterior kind of an imaging of TMJ. So what you actually see is a nice anterior view of the TMJ. Okay, particularly useful in visualizing the condylar neck fracture. Okay, and then we have the submental vertex. We already know how the submental vertex is taken, and it is used to see the angulation of the condylar head, and also it is used for the zygomatic arches if they are displacing inwards or coming in interference with the TMJ. Right? These three views are very important, and they are a little cumbersome when it comes to remembering them. The best way to deal with them is the diagrams. Okay? So look at the diagrams nicely. You should be able to deal with the things. Right? So we'll be having a short discussion class for you all on the radiology itself, probably before we start with the dental materials. And this discussion class will be MCQ based, and we'll put up some MCQs for you all. There is a little bit of miscellaneous section, which I wanted to talk about, the heel effect and some small things, which I'll cover up in the next class. Okay, and go through this portion, solve the MCQs related to this particular portion as early as possible without much delaying, so that you are able to apply this to the MCQs. Okay, so see you all on Monday, and I'll put a few MCQs for you all so that we can just revise the radiology part. Is there any doubt or anything in today's class? Go through it. If you find any doubt, do let me know. I'll just work it out. Okay, and make a habit of marking. Hopefully all of you have seen that particular class wherein we have discussed how to mark your MCQ books and all those things. If not, just refer that, and there is a document also that is there, shared on our Facebook page. So go through that and follow it thoroughly, because it will really help you in the last minutes of exams. Okay, try to come up with the controversial or the wrong questions now itself, rather than keeping everything for your year end. Okay, so, and refer back a few radiology questions on the forum. Are you guys registered on the forum? I'm not sure about that. So visit the forum, and there are many radiology discussions and with pictures over there that will clear a lot of your confusions. So just go through the forum, and it will help you in clearing the doubts. Okay, you can just put radiology on the search and you can find the answers over there. And if you are registering for the forum, it requires approval. So if you register and you are not yet approved, send an email to the so for the approval of your account. So you can just send your username and write an email that kindly approve my account, created on so and so date. Still be able to approve it. Okay? Okay guys, I'll see you all on Monday. Let me know if any doubts or anything. Yeah. A very good night to all of you.